Assalamu alaikum. Now we have to discuss, or we have to go towards the poisoning and overdoses of some of the drugs or the chemical agents. Poisoning may occur with both chemicals or therapeutic drugs. Chemical can be insecticide, and therapeutic drug maybe in higher doses can produce toxic effect. So poisoning can be resolved by both chemicals or therapeutic drugs. So principles, a general principle to tackle such situation includes firstly resuscitation. Under resuscitation, we have to assist ventilation by monitoring the airways, breathing, and circulation. To maintain the ventilation, we have to supply oxygen if patient required, and to obtain the IV access to administrate IV fluid if the patient required. Secondly, gastric decontamination. The ingested toxic or poisonous drug have to be removed from the gut. So we have certain strategies to decontaminate our stomach. Activated charcoal is the safest and effective choice for decontamination of gut. For the adult, we can use 1 gram per kg to maximum 50 gram, and for children, it can be 15 to 30 gram. But activated charcoal have certain limitations. It cannot be effective for hydrocarbon like petroleum or kerosene and anticholinesterase drug, heavy metal, acid, and even alkali. For such situation, we cannot use activated charcoal. It can even harm the situation. We have another choice, gastric lavage, but it can be performed in certain situations like ingestion of heavy doses of paracetamol, or in such cases where the increased risk of bleeding. But it also has limitation. It cannot be used for hydrocarbon, castrates, and corrosive agent because it can further harm the esophageal tract when we try to do gastric lavage in such condition. Then we have supportive care. We should do supportive care. We have to monitor oxygen supply, IV fuel, and maintain the airway. And we have to treat the patient based on their pharmacological response. The pharmacological response of ingested drug is uh, can be used for the base of treatment. Patient have certain intended pharmacological effect that can be treated as supportive care. Then we have some of the antidote for specific drug, like naloxone is antidote for opiates. Then we have to also monitor the psychiatric state of the patient. The self-administration of overdoses are more often expression of distress because of emotional crisis that can be because of suicidal intent. So strategy is to be assessment of suicidal intent and treatment also based on such circumstances. And also the second step should be appropriate counseling of such patient. We have some specific drugs for their specific treatment because of their toxicity, like opiates that show toxicity sign and symptom include constricted pupil, slow breathing, loss of alertness, and treatment involve the maintenance of airways and ventilation. Opiate have some includes like morphine, codeine, Tibaine. It has antidote for its treatment. The specific antidote is naloxone that can be given in the dose of 0.4 mg IV or IM, and it can be repeated in 5 minutes if the symptom is not recovered, and then lead to us 2 mg the maximum, and we have to monitor the patient is recovered or not. Importantly, if if patient is not recovered by naloxone, it can be because some other drug. In case we are unaware of the ingested drug, like it can be of cholinergic drug, which also show that constitute people and similar symptoms because of cholinergic response. Paracetamol can also be fatal in case of higher doses. The symptoms, GI symptoms including nausea, vomiting, abdominal pain, but it can also lead towards hepatic failure in days to weeks. The minimum toxic dose of paracetamol is 150 mg per kg, and even the hepatic failure can be resulted when 350 mg per kg of paracetamol is ingested, and even in days to weeks, hepatic failure can be resulted. For treatment, we have antidote, acetylcysteine, and we have to assess the hepatic failure, which is based on serum paracetamol level and time of ingestion. Acetylcysteine is most effective after the within the 8 hours of ingestion. 150 mg per kg IV, it can be given over 5 minutes, then 50 mg per kg IV for 4 hours, and it can lead towards another dose of 100 mg per kg over extended time, that is 16 hours, depending on the recovery of the patient. Monitoring should be conducted, or patient should be monitored for the bronchospasm, that is a side effect of the drug. So if there is bronchospasm, so it can be managed by salbutamol, that is beta adrenergic drug. In case of anticholinergic toxicity, which can be insecticide, the symptoms are vomiting, diarrhea, bradycardia, hypersalivation, bronchospasm, urinary incontinence, constricted pupil, and pulmonary edema. These all are the symptoms of cholinergic drug, because in case of anticholinergic cholinesterase enzyme is not available, so expression of cholinergic response is potentiated. For the treatment, we have antidote, that is anticholinergic drug, atropine and pralidoxime. Pralidoxime is a reactivator of cholinesterases, and atropine is anticholinergic drug. For adult, 3 mg IV every 5 minutes to maximum 20 to 30 mg we can give, plus pralidoxime 1 gram over 30 minutes, and it can be repeated for about 12 hours if necessary. In children, we can give atropine in 1.2 mg IV over 5 minutes until the patient restores their sinus tachycardia, as in condition is bradycardia block. So to recovery the sinus tachycardia, we are giving atropine plus pralidoxime 20 mg per kg over 30 minutes, and can also be repeated 12 hourly if the symptoms of anticholinergic drug is persisting, like bradycardia. Now, anticoagulants. Anticoagulants drug show their symptoms at increased risk of bleeding. Clotting is not appropriate because of anticholinergic drugs like warfarin. So treatment include vitamin K and fresh frozen plasma to restore their decrease the bleeding tendency. In adult, vitamin K 10 mg IV can be given on daily basis depending on their recovery, and monitoring the plasma prothrombin time. Plus, we can give fresh frozen plasma 2 units IV to maximum 8 units. For the children, we can give 0.3 mg per kg and to maximum 8 mg. And if required, fresh frozen plasma can also be added, that is 20 ml per kg to maximum 2 units. Iron can also lead towards toxicity if ingested in toxic doses. and that can be maybe showing their serum iron level greater than 350 microgram per ml. And even abdominal X-ray, plain abdominal X-ray shows iron tablet, and the patient is symptomatic. And symptoms include diarrhea, vomiting, abdominal pain, even shock, hypoglycemia, and cardiac lymphatic failure can also be resulted. Treatment include injection of IV fuel and glucose to recover hypoglycemia if required. Depending on the assessment, we can also give glucose. The iron has antidose bisphenolphthalein that can be given in 15 mg per kg per hour. The other drug is phenytoin that is producing most potentially cerebral dysfunction, seizures, coma. For management, we have supportive care. Means we have to monitor oxygen supply, IV fluid, and breathing, and the pharmacological responses based treatment. Diazepam can be given to control the seizure, which is associated with phenytoin toxicity. Another toxicity can be produced by carbon monoxide, as for example, car exhaust. Carbon monoxide compete oxygen in binding hemoglobin, so it can also be lethal. Symptoms include headache, nausea, confusion, coma, seizure, and arrhythmia. Treatment based on the strategy as carbon monoxide is competing oxygen, so in binding the hemoglobin, so we have to supply 100% oxygen for at least 12 hours for symptomatic patients. Other drug that can show their toxicity, digoxin. Digoxin showing their symptom anorexia, vomiting, headache, diarrhea, hyperkalemia, that is acute hyperkalemia, arrhythmia, and it can be complete block of ventricular, complete heart block to ventricular tachycardia. There can be tachycardia because of hyperkalemia, and treatment includes supportive first based on their pharmacological response, oxygen supply, and IV fluid management. Treatment of complications associated with toxicity, digoxin toxicity, include like ventricular tachycardia, for which we can give phenytoin 15 mg per kg IV plus magnesium sulfate. It can also be effective for potassium, and it can be maximally 5 gram over 15 minutes. If even the arrhythmia is not recovered, so we can add lignocaine 1 mg per kg IV bolus. If there is bradyarrhythmia, so we have to add a chronotropic drug or anticholinergic drug, that is atropine, to improve the cardiac breathing rate. Because in bradycardia, there is slow rate of breathing, so we have to increase the rate of heart. So we add atropine 5 microgram per kg bolus. It can be repeated in 5 minutes. Now for hyperkalemia, we can give short-acting insulin 10 unit IV bolus plus 50 ml of 50% dextrose, 50% glucose, IV infusion, IV bolus for 5 minutes, and it can be repeated depending on the time, depending on the situation, and depending on the patient condition. If patient is hyperglycemic, so we can avoid this. Other choices we also have, that potassium deoxalate. Now, TCA, tricyclic antidepressant drug, can be toxic showing the symptom of hypotension, ventricular tachycardia, coma, seizure, respiratory acidosis, and it can be even metabolic acidosis due to hypertension and seizure. So the treatment include respiratory for respiratory acidosis due to loss of oxygen or oxygen supply, required ventilation or intubation. For seizure management, we can give diazepam 1 mg per kg OE IV bolus, and it can be repeated every 5 minutes depending on the recovery of seizure condition. For hypotension, we have to give saline, normal saline 0.9 mg, 10 ml per kg bolus, and even if it persists, the hypotension condition is not recovered, so sodium bicarbonate can be added 1 millimole per kg IV bolus, which may be repeated in 5 minutes, depending on the situation. For ventricular tachycardia, lignocaine 1 mg per kg IV bolus can also be added to sodium bicarbonate. Lithium. Lithium is the drug of choice which competing with sodium. Its toxicity show the symptom, gastrointestinal symptom like nausea, vomiting, and diarrhea, CNS symptom, tremor, ataxia, slur speech, loss of balance, and confusion, seizures, coma. After a supportive treatment, like monitoring of oxygen level and ventilation, IV fluid, we have to hydrate the patient with normal saline, 0.9% saline, IV to maintain diuresis, and importantly to excrete the lithium to recover the toxicity of lithium. Alkali ingestion, like bleach, household bleaching. So in such condition, obstruction of airway, esophageal and gastric perforation occur. As we already told, the decontamination cannot be effective. There is even no specific antidote. Treatment only supportive, and we have to hydrate the patient to reduce its toxicity and dilute the bleaching and excretion. If the toxicity is because of aliphatic hydrocarbon, that can be kerosene and petroleum, the symptoms include irritation of GI, causing abdominal pain, vomitings, and diarrhea, and even pneumonitis. Pneumonitis can be resulted when the patient vomit and aspire. So in the lungs, hydrocarbon can reach and it result in pneumonitis. Treatment, as we have already told, there is no role of activated charcoal in case of hydrocarbon. We have to supply oxygen, hydrate the patient to manage the situation. That's all for today's class and toxicity of drugs or poisons. Inshallah, the next class we will go towards next topic. Allah Hafiz.